بسم الله الرحمن الرحيم. أعزائي طلبة الفرقة السادسة، معاكم دكتور أحمد شفيق. إن شاء الله هشرح لكم النهاردة موضوعين مهمين في الجراحة، موضوع الميزنتريك فاسكولار اوكلوجن وموضوع الجاسترو-انتستينال فيستولا. قبل ما نشرح الموضوعين دول هشرح لكم بسرعة كده نبذة مختصرة عن الانتستينال اناتومي. The intestine is the longest part of the digestive tube and is divided into small intestine and large intestine. Food has to be digested, metabolized, and stored for expulsion in the intestine. The small intestine extends from the pylorus to the ileocecal junction, about 6 meters long and 2.5 to 3 centimeters in diameter. The surface area of the human small intestine about 30 square meters. The length is greater in males than females. The small intestine receives bile juice and pancreatic juice through the pancreatic duct, controlled by the sphincter of Oddi. The junction between the small intestine and the large intestine is the ileocecal junction, which is controlled by the ileocecal sphincter. Histology of the small intestine: Plicae, which is transverse folds of the intestinal lining, villi, lacteals, and intestinal glands. Duodenal glands or Brunner glands produce mucus, buffers, and urogestrone. The function of Brunner glands is neutralization of the acidic juice of the stomach. Regions of the small intestine: duodenum, jejunum, and ileum. The duodenum means 12 fingers. The duodenum is a short structure, about 20 to 25 centimeters long, continuous with the stomach and shaped like a C. It lies above the level of umbilicus, opposite the first and second and third lumbar vertebrae. It surrounds the head of the pancreas. The duodenum receives gastric chyme from the stomach, together with the digestive juice from the pancreas and the gallbladder. The digestive enzymes break down proteins and bile emulsify fats into methanols. The duodenum contains Brunner glands, which produce mucus-rich alkaline secretion containing bicarbonate. These secretions, in combination with bicarbonate from the pancreas, neutralize the acidic juice from the stomach. Suspensory ligament of the duodenum, or ligament of Treves, is a fibromuscular band which suspends and supports the DG flexure. It arises from the right crus of the diaphragm, close to the right side of the esophagus, passes downwards behind the pancreas, and is attached to the posterior surface of the DG flexure and the third and fourth part of the duodenum. دي صورة لل DG flexure and ligament of Treves. The duodenum is divided into 4 parts: the first part or the superior part, second part descending, third and fourth part. The first part of the duodenum lies anterolateral to the body of L1 vertebrae, most movable part. The second part descends along the right side of L1 through L3 vertebrae. Third part crosses L3 vertebra. The fourth part of the duodenum or ascending part begins at the left of L3 and rises superiorly as far as superior border of L2 and continues with jejunum. Blood supply of the duodenum: arterial supply, superior pancreatico-duodenal artery, ده جاي من the celiac trunk. Inferior pancreatico-duodenal artery from the superior mesenteric artery. Venous supply: the veins of the duodenum drain into splenic, superior mesenteric and portal veins. The jejunum is the midsection of the small intestine connecting the duodenum to the ileum. It is about 2.5 meters long and contains the plicae circularis and villi that increase its surface area. Products of digestion: sugar, amino acids, and fatty acids are absorbed into the bloodstream here. The suspensory ligament of the duodenum marks the division between the duodenum and jejunum. The ileum is the final section of the small intestine. It is about 3 meters long and contains villi similar to the jejunum. It absorbs mainly vitamin B12 and bile acids, as well as any other remaining nutrients. The ileum joins to the cecum of the large intestine at the ileocecal junction. دي مقارنة بين الجejunum والإليوم. الجejunum بيبقى لونه deeper red. الإليوم بيبقى paler pink. الوول thick في الجejunum والthin في الإليوم. الفاسكولاريتي بتبقى greater في الجejunum وليس في الإليوم. الفاسكولار arcades بتبقى few in the jejunum and more and many short loops in the ileum. Vasa recta بتبقى long في الجejunum وshort في الإليوم. الفات الميزنتري بيبقى less in jejunum and more in ileum. Circular folds of mucosa أو البلايكي circularis بتبقى large, tall and closely packed in the jejunum low and spare or absent in the distal parts of the ileum. Lymphoid nodules بتبقى few in the jejunum and many in the ileum. mesentery. الميزنتري بيبقى شكله fan shaped fold of the peritoneum that suspends the jejunum and ileum from the posterior abdominal wall. It consists of two layers derived from the greater sac. Root of the mesentery بيبقى about 15 centimeters long and extends from the left side of L1 vertebra at the DG junction to the right sacroiliac joint at the ileocecal junction. The wall of the small intestine is made of the following layers: serosal coat, muscular coat, submucosa, and mucosa. The blood supply of the ileum and jejunum. Arterial supply from branches, ileal and jejunal branches from the superior mesenteric artery. Intestinal branches arise from the left side of the artery and runs in the mesentery to reach the gut. They anastomose with one another to form a series of arcades. Lowest part of the ileum is supplied by the ileocolic artery. Venous drainage. Veins correspond to the branches of the superior mesenteric artery and drain into the superior mesenteric vein. Nerve supply. Nerve supply are derived from sympathetic and parasympathetic nerves. دي صورة للبلايكي سيركولاريز أو الميكوزال فولدز. بتبقى circular folds, large valvular flaps projecting into the lumen of the small intestine. بتبقى more prominent in the jejunum. Intestinal glands or crypts of Lubberkin. They are simple tubular glands distributed over the entire mucous membrane of the jejunum and ileum. They open by small circular apertures on the surface of mucous membrane between the villi. They secrete digestive enzymes and the mucus. The mucous membrane of the small intestine contains two types of lymphatic follicles: solitary lymphatic follicles and aggregated lymphatic follicles or Peyer's patches. Peyer's patches are ulcerated in typhoid fever, forming oval ulcer with their long axis along the long axis of the bowel. الجزء الثاني بتاع الانتستين اللي هنشرحه دلوقتي اللي هو large intestine. The large intestine extends from cecum to the anus and is divided into cecum, appendix, ascending colon, transverse colon, descending colon, sigmoid, rectum, and anal canal. The cecum is the part of the large intestine that lies below the level of the junction of the ileum and the large intestine. It is a blind-ended pouch that is situated in the right iliac fossa and is completely covered with peritoneum. It possesses a considerable amount of mobility. The longitudinal muscles is restricted to the three flat bands, the tenia coli. دي صورة بتوضح relations of the cecum. Posteriorly, the right psoas muscle, the iliacus muscle, the femoral nerve, the lateral cutaneous nerve of the thigh, the appendix is commonly found behind the cecum. Ileocecal junction. The terminal part of the ileum enters the large intestine at the junction of the cecum with the ascending colon. The opening is provided with two folds or lips, which is called the ileocecal valve. The appendix communicates with the cavity of the cecum through an opening located below and behind the ileocecal opening. Blood supply, lymphatic drainage, and innervation of the cecum. Blood supply of the cecum بيبقى جاي من الإليوكوليك artery وده branch من superior mesenteric artery. The veins correspond to the arteries which drain into the superior mesenteric vein. Lymphatic passes through several mesenteric lymph nodes and finally reaches superior mesenteric nodes. الليمفاتكس في جي اي تي بتفولو الارتيريال سبلاي يعني بتمشي مع الارترز. النيرف سبلاي برضو في سمباثيك وباراسمباثيك. السمباثيك بيبقى inhibitory والباراسمباثيك بيبقى stimulatory. Appendix is a narrow muscular tube containing a large amount of lymphoid tissue. The base is attached to the posterior medial surface of the cecum and the remainder of the appendix is free. It has a complete peritoneal covering which is attached to the mesentery, the small intestine, by the mesoappendix. The mesoappendix contains the appendicular vessels and the nerves. The tip of the appendix may be found in the following positions: into the pelvis, against the right pelvic wall, behind the cecum, the lateral side of the cecum, in front or behind the terminal part of the pelvis. The first and second positions are the most common sites. Surface anatomy of the appendix. The base of appendix lies in the right iliac fossa and is situated 1/3 of the way up the line joining the right anterior superior iliac spine to the umbilicus, which is called McBurney's point. Blood supply of the appendix. The appendix is supplied by appendicular artery, which is a branch from the posterior cecal artery from the iliac artery اللي بيبقى جاي من superior mesenteric artery. The veins drain into the posterior cecal vein. The lymph vessels drain into one or two nodes lying in the mesoappendix and then into the superior mesenteric nodes. دي صورة بتوضح ال ascending colon. The ascending colon extends upward from the cecum to the inferior surface of the right lobe of the liver, where it turns to the left, forming the right colic flexure or the hepatic flexure, and become continuous with the transverse colon. The peritoneum covers the front and the sides of the ascending colon, binding it to the posterior abdominal wall. The blood supply of the ascending colon comes from the ileocolic and tricolic branches of the superior mesenteric artery. The veins correspond to the arteries and drain into superior mesenteric vein. The lymph vessels drain into lymph nodes lying along the course of the colic blood vessels and ultimately reaches superior mesenteric nodes. The transverse colon extends across the abdomen, occupying the umbilical region. It begins at the right colic flexure, below the right lobe of the liver, and hangs downward, suspended by the transverse mesocolon from the pancreas. It then ascends to the left colic flexure below the spleen. The left colic flexure or the splenic flexure is higher than the right colic flexure and is suspended from the diaphragm by the parenchycolic ligament. The transverse mesocolon suspends the transverse colon from the anterior border of the pancreas and is attached to the superior border of the transverse colon, and the posterior layers of the greater omentum are attached to the inferior border. دي صورة بتوضح relations of the transverse colon. Posterior is the second part of the duodenum, the head of the pancreas, and coils of the jejunum and ileum. Blood supply of transverse colon. The proximal 2/3 are supplied by the middle colic artery, which is a branch from the superior mesenteric artery. The distal third is supplied by the left colic artery, which is a branch from the inferior mesenteric artery. The veins correspond to the arteries and drain into superior and inferior mesenteric veins. Lymphatic drainage. The proximal 2/3 drain into the colic nodes and then into superior mesenteric nodes. The distal third drains into the colic nodes and then the inferior mesenteric nodes. دي صورة بتوضح الارterial blood supply of the large intestine. زي ما انتم شايفين كده، ده الاورطة طالع منه two branches. superior mesenteric artery. superior mesenteric artery بيسبلاي الترانسفيرس كولون، بيسبلاي right 2/3 of the right transverse colon. السوبيريور ميزنتريك ارتري بيدي الميدل كوليك وبيدي الرايت كوليك وبيدي الاليو كوليك ارتريز. الانفيريور ميزنتريك ارتري بيدي الليفت كوليك ارتري وبيدي السيجمويدال برانشز وبيدي superior rectal artery. بيبقى فيه communications between the inferior mesenteric and superior mesenteric artery عن طريق the marginal artery of Bramon. دي تعتبر مثال ل collateral circulation. The descending colon is about 10 inches. It extends downward from the left colic flexure to the pelvic rim, where it becomes continuous with the sigmoid colon. The peritoneal covers the front and sides and binds it to the posterior abdominal wall. Posteriorly, the lateral border of the left kidney, the origin of the transversus abdominis muscle, the quadratus lumborum, and the iliac crest. The iliohypogastric and the ilioinguinal nerves, the lateral cutaneous nerve of the thigh, and the femoral nerve. دي صورة برضو بتوضح relations of the descending colon. Blood supply of the descending colon comes from the left colic artery and sigmoidal branches of the inferior mesenteric artery. The veins correspond to the arteries and drain into the inferior mesenteric veins. The lymph nodes and the left colic lymph nodes and the inferior mesenteric nodes around the origin of the inferior mesenteric artery. The sigmoid colon is about 10 to 15 inches long and begins as a continuation of the descending colon in front of the pelvic rim. The sigmoid colon is attached to the posterior pelvic wall by a fan-shaped sigmoid mesocolon. The blood supply of the sigmoid comes from the sigmoidal branches of the inferior mesenteric artery. The rectum is about 5 inches long. It begins in front of the third sacral vertebra as a continuation of the sigmoid colon. It passes downward following the curve of the sacrum and coccyx, ends in front of the tail of the coccyx by piercing the pelvic diaphragm and becoming continuous with the anal canal. The lower part of the rectum is dilated to form the rectal ampulla. The puborectal portion of the levator ani muscles forms a sling at the junction of the rectum and anal canal and pulls part of the bowel forward, producing the anorectal angle. The peritoneum covers the anterior and the lateral surface of the first third of the rectum and only the anterior surface of the middle third, leaving the lower third devoid of peritoneum. Relations of the rectum. Posteriorly, the rectum is in contact with the sacrum and coccyx by it forms psogeus levator ani muscles. Anteriorly, in male, it's related to sigmoid colon, rectovesical pouch, the bladder, termination of the vas deferens, and the seminal vesicles on each side, and the prostate. In females, it is related to the sigmoid colon, rectouterine pouch or Douglas pouch, posterior surface of vagina. Blood supply of the rectum, the superior and middle and inferior rectal arteries. The superior rectal artery is a direct continuation of the inferior mesenteric artery and is the chief artery supplying the mucous membrane. The middle rectal artery is a small branch of the internal iliac artery and is distributed mainly to the muscular coat. The inferior rectal artery is a branch from the internal duodenal artery. Veins of the rectum correspond to the arteries. The superior rectal vein is a tributary of the portal circulation and drain into the inferior mesenteric vein. The middle and inferior rectal veins drain into the internal iliac veins and internal duodenal veins. The union between the rectal veins form an important portosystemic anastomosis. دي صورة برضو بتوضح البورتوكيفال anastomosis. Lymph vessels of the rectum drain first into the pararectal nodes and then into the inferior mesenteric nodes. Lymph nodes from the lower part of the rectum follow the middle rectal artery to the internal iliac nodes. Difference between small and large intestine. The small intestine is mobile, whereas the ascending and descending parts of the colon are fixed. The caliber of the small intestine is smaller than that the large intestine. The small intestine has a mesentery that passes downward across the midline into the right iliac fossa. The longitudinal muscles of the small intestine forms a continuous layer around the gut. In the large intestine, the longitudinal muscle is collected into 3 bands, which is called the tinea colli. The small intestine has no fatty tags attached to its wall. The large intestine has a fatty tag called the appendices rhabdoici. The wall of the small intestine is smooth, whereas the large intestine is sacculated. ندخل على الموضوع التاني اللي هنشرحه النهارده وهو الجاستروانتستينال فيستولا. Fistulas are abnormal communication between two epithelial lined surfaces. Gastrointestinal fistula represent abnormal duct-like communication between the gut and another epithelial lined surface. Maybe organ system, maybe skin surface or GIT tract itself. Classification of gastrointestinal fistula anatomically may be internal or external. Internal ممكن تبقى enteroenteric, enterovesical, nephroenteric, enterovaginal, enterouterine, aortoenteric. external لما تبقى فاتحة على السكن بيبقى اسمها enterocutaneous fistula. Physiological classification according to the output of the fistula. low output fistula الاماونت بتبقى اقل من 200 مللي بير داي. مودريت اوتبوت بتبقى من 200 ل 500 مللي بير داي. هاي اوتبوت فيستولا بتبقى اكتر من 500 مللي بير داي. etiologic classification may be traumatic, post operative, ingested foreign body, penetrating trauma, infectious, diverticulitis, appendicitis, actinomycosis, TB, Crohn's, enteritis, malignancy, radiation. How to prevent fistula? Acute intraoperative perforations must be identified early and closed. Serosal tears should be repaired immediately. Aggressive adhesolysis should be avoided to prevent serosal tears. Diagnosis of perforation and fistula. Post-operative anastomotic leak, fever, abdominal pain, continuous drain discharge, continuous drain containing intestinal content, general condition not improving. Evaluation of a patient with gastrointestinal fistula. History, physical examination, radiological studies, and laboratory studies. Image study, fistulography, oral contrast or contrast enema, pyelography, cystography. Other investigations may be endoscopy, CT abdomen and pelvis, MRI, or plain X-ray. The management of gastrointestinal fistula. Conservative management and surgical management. Conservative management include fluid resuscitation, correction of acid base and chloride imbalance, complete bowel rest, nutritional support, infection control, fistula drainage, skin protection. Nutritional support. Early and aggressive parenteral nutrition therapy has dramatically decreased mortality from fistula. It decreases the fistula output, modify the composition of gastrointestinal and pancreatic secretion. The role of total parenteral nutrition: reduce the maximal secretory capacity of the gastrointestinal tract, total parenteral nutrition complications, bacterial translocation, superinfection, metabolic disorders. Nutritional support: enteral feeding or parenteral nutrition, or re-infusion into the distal bowel. Infection control: intra-abdominal abscess may be drained, intravenous antibiotics, and the care of the wound. Fistula drainage: wound management, dressing, intubation, or vacuum assisted drainage. Pharmacotherapy: steroid H2 receptor antagonist. Surgical treatment: بنلجأ للsurgical treatment if fistulas fail to heal with non-operative measures or in sepsis or high output fistula. Spontaneous closure of gastrointestinal fistula is unlikely due to the following factors: foreign body, radiation injury, inflammatory bowel disease, epithelialization of fistular tract, neoplasia, or distal obstruction. The outcome is unfavorable in lateral fistula, large adjacent abscess, adjacent bowel disease, distal obstruction, fistula tract أقل من 2 سم with epithelialization, enteral defect more than 1 cm, gastric fistula, duodenal fistula, fistula at DG, or ileal fistula. دي صور لجاستروانتستينال فيستولا. الموضوع الثالث والأخير اللي هشرحه لكم النهارده إن شاء الله اللي هو الأكيوت ميزنتريك اسكيميا. قبل ما نبدأ في الأكيوت ميزنتريك اسكيميا هفكركم سريعا كده بالبلاد سبلاي، اور هكلمكم mainly على الارتيريال سبلاي اوف ذا جي اي تي. احنا عارفين جي اي تي امبريولوجيكالي في فور جات وفي ميد جات وفي هايند جات. في اللي بيغذي الفور جات اسمه سيلك ترانك. سيلك ترانك بيدي 3 مين برانشز، بيدي الليفت جاستريك، وبيدي الكومن هيباتيك ارتري، وبيدي السبلينيك ارتري. السبلينيك ارتري بيسبلاي البنكرياس وبيدي السبلين، بيدي الليفت شورت جاستريك وبيدي الليفت جاستروبيبلويك. ذا كومن هيباتيك ارتري بيدي الجاسترو ديودينال ارتري، وبيدي الهيباتيك ارتري بروبر اللي بيدي بعد كده الرايت والليفت هيباتيك ارتريز. الجاسترو ديودينال ارتري بيدي superior pancreatico duodenal arteries، وبيدي كمان الرايت جاستروبيبلويك. ده اللي هو الارتري اوف ذا فور جات. بعد كده في superior mesenteric artery بيطلع بأكيوت أنجل من الأورطة، وبيدي الانفيريور بنكرياتيكو يودينال artery، وبيدي الميدل كوليك artery، وبيدي الجيجنال والإليال برانشز، وبيدي الرايت كوليك، وبيدي الإريو كوليك artery. بعد كده الانفيريور ميزنتريك artery، وبده بيسبلاي الديستال سيرد اوف ذا ترانسفيرس كولون والديسندنج كولون والسيجمويد والريكتم، وده بيدي الليفت كوليك artery، وبيدي سيجمويدال برانشز، وبيكمل superior rectal artery. في حاجة اسمها marginal artery of the lamont، ده يعتبر collateral circulation between the superior mesenteric and inferior mesenteric artery. The marginal artery is a weak link at the junction of mid and hind gut along the transverse colon. Acute mesenteric ischemia is a catastrophic abdominal emergency characterized by sudden critical interruption to the intestinal blood flow, which commonly leads to bowel infarction and death. It is uncommon but life-threatening condition. Mortality remains as high as 60 to 80%. Prognosis is poor. Mesenteric ischemia may be acute mesenteric ischemia or chronic mesenteric ischemia. Well, acute mesenteric ischemia may be arterial or venous or non-occlusive. الارتيريال ممكن يبقى سببها امبوليزم or thrombus. الفينوس occlusion بيبقى سببها mesenteric venous thrombosis. والنون اوكلوسيف mesenteric ischemia بتمثل حوالي 15 ل 20% من الحالات. دي صورة بتوضح السايتس اوف occlusion. في حالات الامبوليزم بيبقى الاوكلوجن mainly around the middle colic artery or the distal branches of the superior mesenteric artery. Superior mesenteric artery thrombosis بتبقى mainly at the ostium of the superior mesenteric artery. Embolism is the commonest cause of acute mesenteric ischemia. Majority of emboli arise from the heart, most commonly the left atrium in the patients of atrial fibrillation. Superior mesenteric artery is most commonly affected due to its acute angle of origin from the abdominal aorta. Acute mesenteric ischemia due to thrombosis commonly involves the aortic ostium. Thrombosis here on top of atherosclerosis. Prognosis is worse than embolic ischemia. Often previous history of intestinal angina, fear of eating, significant weight loss. Acute mesenteric ischemia due to non-occlusive disease results from systemic hypoperfusion, most lethal because one arterial vasospasm is initiated and it may be persist even after correction of the initiating event. The prognosis is very bad. Acute mesenteric ischemia due to venous thrombosis is least common, typically affects the superior mesenteric vein and rarely the mesenteric vein. الامبوليزم الأسباب بتاعتها بتبقى في الغالب العينين دول عندهم AF or Muir's thrombus after myocardial infarction or prosthetic heart valve. Thrombosis بيبقى سببها mesenteric atherosclerosis. non-occlusive mesenteric ischemia mesenteric vein thrombosis بيبقى سببها العينين دول بيبقى عندهم زي أسباب الدي في تي، بيبقى عندهم hyper coagulable state. Classical description of early symptoms: severe abdominal pain that is out of proportion to physical findings in 95 cases. Early diagnosis require high index of suspicion. Early بيبقى فيه prominent symptoms of GIT emptying, nausea, vomiting, diarrhea. late بيبقى فيه bloody diarrhea, abdominal distension and features of peritonitis. pathophysiology أول حاجة بيحصل ischemia، بعد كده بيحصل mucosal barial disruption، بيحصل حاجة اسمها bacterial translocation، بيحصل release of bacteria and toxins and vasoactive substances. بعد كده العيان بيخش في systemic inflammatory response syndrome, multi organ failure and death. The time factor is very important in cases of acute mesenteric ischemia. بعد 15 دقيقة بيحصل structural change to the intestinal villi. بعد 3 ساعات بيحصل mucosal sloughing. بعد 6 ساعات بيحصل transmural necrosis, gangrene and perforation. Investigations في حاجات laboratory و radiological. Most common laboratory abnormalities are hemoconcentration, leukocytosis، دايما نلاقي الوايت بلاد سيلز أكتر من 16، metabolic acidosis, lactic acidosis, raised amylase and alkaline phosphatase. البرين إيركت بتاع العينين دول بيبقى فيها dilated bowel loops, thumb printing sign signifying bowel wall edema and thickening, nematosis intestinal. بعد كده ممكن نعمل العينين دول دوبلر التراساوند. The most important investigation is angiography. في ممكن يبقى non invasive وده the best اللي هو CT angiography or MR angiography. ممكن كان زمان بيبقى في حاجة اللي هي conventional angiography or invasive method. Findings on angiography: filling defect, stenosis or block. The angiography showing stenosis of the superior mesenteric. CT angiogram showing partial thrombosis of the superior mesenteric. 3D CT angiography showing superior mesenteric artery occlusion. Management: patient presents with severe abdominal pain consistent with ischemic bowel. لو العيان ده عنده peritoneal signs يبقى هنعمل العيان ده laparotomy وهنعمل revascularization and bowel resection. لو العيان ده مفيش فيه ischemic bowel ومفيش فيه peritoneal sign، مفيش فيه قصدي peritoneal signs، هنعمل العيان ده بقى نعمل له الانفستيجيشنز ونبدأ نقيم العيان مظبوط ونحاول نعمل له هيبرانيزيشن ونشوف هنتعامل معاه ايه ازاي. definitive surgical exploration بنعمل العيانين دول midline laparotomy, assessment of the bowel viability, determination of the underlying cause, mesenteric revascularization, resection of necrotic bowel. ممكن في بعض الحالات بنعمل لها second look laparotomy. assessment of bowel viability بنحكم على ال viability of the intestine، ممكن clinically، ممكن دوبلر ultrasound or fluorescein. clinically بتبقى لو ال intestine viable بتبقى pink وفيها visible peristalsis فيها positive pulsations في الميزنتري بتاعها و bleeding from cut edges. assessment of the bowel viability: لو لقينا الباول gangrenous هنعمل bowel resection. لو لقينا الباول equivocal or marginally viable ممكن نعمل revascularization procedures، أو ممكن في بعض الحالات لو اللوبس suspicious بنعمل second look laparoscopy. mesenteric revascularization لو في ده لو لحقنا العيان early قبل ما يحصل جانجرين، بنحاول نعمل العينين دول لو هي امبوليزم بنعمل بالون كاستر امبوليكتومي، واحيانا برضو بعض الحالات تحتاج تين باتش انشوبلاستي. لو هو سببها ثرومبوزس بنعمل ثرومبكتومي وبنعمل بايباس جرافت اور ري امبلانتيشن اوف ذا سوبيريور ميزنتريك. resection of the necrotic bowel لو هي frankly necrotic بنعملها resection. لو هي marginally viable bowel او equivocal may improve over hours consider second look laboratory. Who should have second look laparotomy? Some surgeons advocate routine second look laparotomy to reduce the mortality rate. Others adopt a selective approach and perform a second look laparotomy when patient deteriorates clinically. Alternative to surgery في حاجة اسمها endovascular therapy. ده limited في ال acute situations, only indicated in early cases without bowel infarction. لو في acute superior artery thrombosis بنعمل percutaneous transluminal balloon angioplasty and stenting، أو بنعمل transarterial thrombolysis. لو هو non-occlusive mesenteric ischemia بنعمل transarterial infusion of vasodilator. Management of non-occlusive mesenteric ischemia: correction of underlying condition, optimize fluid status and improve cardiac output, eliminate vasopressors, consider catheter directed intra-arterial infusion of vasodilator, laparotomy of peritoneal signs developed. Management of mesenteric venous thrombosis: anticoagulation with heparin is the mainstay of treatment, workup for coagulability, laparotomy if peritoneal signs develop. Acute mesenteric ischemia is an abdominal emergency, both if physical signs are present or absent. We have very less time for investigation, so assessing clinically is very important. Every minute we waste is every centimeter of small bowel we lose. Angiography is diagnostic as well as therapeutic. Preoperative heparin infusion and postoperative paraffin infusion is a must. Still, prognosis is poor and mortality is high. Thank you.